Hi everybody, my name is Aoife Kerwin. I'm the Information Advocacy and Research Officer with MS Ireland. We're delighted to bring Dr. Karen O'Connell onto this webinar this evening to discuss progressive MS, and this webinar is kindly sponsored by Roche. Dr. O'Connell is a consultant neurologist and she is here to chat to us about progressive MS and answer any of the questions that you might have on it. So I'm going to hand you over to Dr. O'Connell to go through the presentation, and we might hold questions to the end. You can submit your questions to us through the Q&A function. It's a little icon that has two little speech bubbles, and we will get to your questions at the end of it. We'll try and answer as many as we can, but I can't promise we'll get to all of them. So with that, I'm going to hand you over to Dr. O'Connell. Thank you.
So thank you, everybody. We're delighted that so many people could join us this evening. I think what I've done and what in discussion with MS Ireland we've decided is that we would keep a presentation very short, and really the whole aim of this evening would be an opportunity for people to ask questions that we could then expand on and discuss a little bit further. So I'm just going to quickly go through these slides, and then Aoife's going to be in charge of the questions after that, if that's okay. So I suppose this is something that I think many people may have seen at MS talks in the past, and MS, I suppose we think of as being on a spectrum, okay? And the majority of cases begin in what's called relapsing remitting MS. So about 85% of people will present in this way. And the typical kind of description of this is that the patients will have an event. Might be an optic neuritis where maybe vision is impaired in one eye. It might be tingles down one side of the body. It might be more dramatic. It might involve weakness down one side of the body. And this will persist for maybe a couple of days to a number of weeks, and then recovery will happen. And patients then may remain very well for a period of time and then may experience another episode. And I suppose what we know over time is that maybe symptoms might persist a little bit, and that things like walking maybe don't fully go back to normal. And this is the kind of crux where you cross over into perhaps having more progressive disease. In terms of, I suppose, breaking it down and looking at progressive disease, so about 15% of cases will have what's called primary progressive MS, okay? And this is a little bit different in how it presents to secondary progressive MS. So in this case, patients tend to be a little bit older, so it tends to be more common in kind of 40s and 50s. It tends not to be so different in terms of gender. So we know that relapsing remitting MS is much more common in women than men, about 2 to 3 times more common. But with progressive MS, it's much more equal. And it's an insidious onset. So it's kind of something that kind of happens and kind of builds up over kind of months to years, and it begins kind of very subtly. And it may be that, you know, going for a walk, that you start to notice that you're just a bit slower than you used to be, or that perhaps after hitting a certain distance, and this can vary from person to person, the foot might catch as you're walking. And gradually over time, you notice that that's actually getting shorter and shorter. It may occasionally present with kind of concentration, memory problems. This is less common, and it may present then with balance problems and being very unsteady when you're walking. And I think it really is all part of the same spectrum. I think when you look at the kind of pathology, when you look at what's going on in the brain, when you look at the imaging, it really is the same. So I think it's all the same disease, it's just on a spectrum. And then if we move over towards what is secondary progressive MS, so as I said to you, about 85% of MS begins as relapsing remitting. And over time, and this data is really coming from a lot of older studies, but about 2/3 of people will develop what's called secondary progressive MS. And this is a bit difficult to define, and there's lots of discussion out there what this really means and how do we diagnose it. And there's not really consensus, so there's lots of people who have different opinions, but I think in essence what everyone agrees on is that it's some worsening of symptoms without there being any relapses. So again, that kind of, as I said to you, maybe that insidiousness where you notice your walking is just not as good as it was, or the distance you're able to do maybe before the foot catches is not as good as it was before. But the symptoms can be very, very broad. It can affect balance, it can affect bladder, it can affect memory. So, you know, we need to think about everything. And we're looking for just things getting slightly worse over time. And it tends to be very, very gradual. Um, and and I suppose it can often be very difficult to diagnose, and it can take kind of a number of years maybe before someone is told, well, no, this is secondary progressive MS. And I suppose the dogma, you know, below where I said about 2/3 of people will enter the secondary progressive phase, I think that that viewpoint is based on some very older studies where none of maybe the newer drugs or newer treatments were available. And if you look at some of maybe the newer studies from the United States or from Sweden, it looks now like these rates are probably a little bit lower. But not only that, that perhaps even though people might develop some progressive symptoms, it seems to happen later. So I think that's, I suppose, another kind of interesting or positive thing when we think about managing MS. This is a scale I just popped up because I think it's something that you hear and just to try and visualize what it actually means. So this is the EDSS. It's a scale that's used kind of across the board in clinical trials and clinics across the world, kind of looking at what they call disability in MS. It's kind of crude because it focuses, I suppose, quite heavily on people's walking ability and not so much on other things like memory, hand function, bowel, bladder function. Although they're involved in the score, they're not as heavily weighted towards that. There are a couple, I suppose, landmarks just to be aware of, because these often are what are used for inclusion and exclusion criteria for trials and for treatments. So an EDSS of 3 or 4 is usually considered kind of moderate disability. So in this category, it may be that you still walk without needing sticks or anything like that, but that the distance is shorter. So it might be about 500 meters, and then you would have to rest or take a break. And the other kind of key landmark, I guess, is the EDSS of 6 or 6.5, which is often the kind of cutoff for some of these trials. And this would mean that when walking, people would need to use a stick for 6, or for 6.5, assistance on both sides. That might be 2 sticks, a rollator, and could still manage to go about 20 meters. I think the kind of the concept of progressive MS and what it means, as I said to you, is very difficult to define. And you know, what does it mean if I've got progressive MS? Am I not having relapses, or can I not have MRI changes? And I guess the idea of kind of showing that it's really a spectrum, so that we talk about people who have some progression, but perhaps they've also had a new relapse, have new relapses, but they're no progression, so their walking things are staying the same. People who have had some slow progression, but no, say, new symptoms or no new changes on their MRI. And then people who are just very stable, who feel like things aren't changing. I think this is really just to try and illustrate the same kind of concepts, this whole idea of, so these big high arches here and the kind of active symbols, so these kind of represent new clinical symptoms or new activity on a scan. And in the beginning, we see that things come back to a kind of a baseline and they stay the same. And then perhaps there might be another event, and again, they come back to a baseline and stay the same. But over time, what we can see is, rather than kind of staying the same, we just see this slight change or slight worsening. And it's kind of around this point that we're sort of entering the secondary progressive phase. And I guess one of the hallmarks of this phase, while you can have relapses, they're just much less common. So I think that's just trying to illustrate that. I think this is really where I hope we're going to have lots of discussion, and there'll be lots of questions, and we can talk potentially about it, because I think this is something that always really interests people. You know, I think the treatment approach has to be broad. I think there's lots of aspects of the disease we have to think about and manage. I mean, we always obviously manage relapses acutely. That might involve coming into hospital, or that might involve taking steroids. I think symptom management is a huge part of MS. So as the disease progresses, we have more symptoms. Our bladder mightn't work as well. We might be running to the loo more often. We may have issues around bowel function. We may have issues around pain spasticity, stiffness, or jumping of the muscles. And I think these are, this is a huge part of monitoring your disease in clinic, and trying to manage it, and making sure that we can manage all the symptoms so that quality of life is as good as it can be. The third part, I suppose, is looking at disease modifying therapies. So these are treatments that have been developed to try and reduce the chance of you having a relapse or of your disease progressing. And I think that we'll have a look at this in a little bit more detail in a minute. And then the final one, which I think is really important as we age anyway. So there's lots of things in life that are aging our brain, like smoking, blood pressure, high cholesterol, diabetes. And I think it's really, really important that we're aware of that, and we do everything we can to keep ourselves as healthy as possible. The treatments that have been kind of investigation clinical trial have come through clinical trial and are now very close to being licensed, and one is available for MS, is a drug called ocrelizumab in primary progressive MS, and a drug called siponimod in secondary progressive MS. They did a large study looking at a drug called natalizumab, or Tysabri, you might know it better as, which unfortunately failed to show any real benefit, and as such wasn't licensed. I think in the discussion we'll probably touch on both of these in a little bit more detail. This is a really good graphic, I think, because it just shows how broad the symptoms of multiple sclerosis can be, and how broad, how many areas that we need to kind of really think about and review when we see people in clinic and ask about, and also the potential to improve all of these and make quality of life better. I suppose I did touch on it there, but I think brain health is very important, and I think it often gets overlooked. And patients come into clinic and they say, oh, my GP told me it was my, this is my MS, and they're having palpitations or their blood pressure is a bit high. And, I think what we need to be clear about is that there, because you have MS does not mean you won't have high blood pressure, you won't have high cholesterol, and these are really good and really important things to target and treat. And we know that the long-term outcomes with controlled blood pressure, controlled cholesterol are much, much better. I think this is nice. So I suppose keeping ourselves active. So I think kind of exercising the mind a little bit. So I often see people in clinic and they love doing puzzles or Sudoku. And I think these things are really important just for kind of keeping things ticking over. I suppose alcohol in moderation. Cigarettes are actually a big one, and there's quite an interesting study from Sweden where they looked at people who on diagnosis stopped smoking and people who continued to smoke, and saw that people who continued to smoke perhaps entered the progressive phase a little bit earlier. So it's definitely something that would kind of benefit health. And then I suppose looking after kind of weight and diet and eating well. So they're my main slides, and I think what Aoife's going to come back on now, and she's going to go through the questions you've submitted, and if there's anything anyone wants to ask or wants me to expand on, I'd be very happy to.
Great, and thank you, Dr. O'Connell. That was wonderful. And we do have a few questions in, so please continue to send them in. We're lucky to have Dr. O'Connell here with us for a little while this evening, so please do send in your questions and we'll try and get through as many as we can. One of the questions that's come in is to maybe discuss the difference between what primary and secondary progressive MS is.
So I think that's a really good question, and it can be hard to kind of tease out. So primary progressive MS is really, as I said kind of in the talk there, it's people who've never really had that clear defined history of having relapses or having episodes like an optic neuritis where the vision maybe is impaired in the eye, but from the beginning things have slightly gotten worse, and the commonest presentation is actually just very slowly noticing that the legs or the walking distance is reduced. And this can be very, very subtle. It can happen over kind of months to years. So, I mean, I saw someone in clinic who was kind of an avid hill walker, and he used to walk, for 4 hours at the weekend, but he just started to notice, towards the end, he was catching his foot when he was coming down. And then he kind of felt over another 6 months actually wasn't able to go the 4 hours. The distance was kind of gradually shortening. And it got to the point really where he couldn't manage kind of the high hills. It was more that he was better on the flat. So it's that kind of very insidious, just getting slowly worse. He never had any kind of episodes or bouts or relapses. Whereas secondary progressive MS tends to follow relapsing remitting MS. So the onset for the majority of people will involve having an MS symptom or relapse. Usually we see people get better, and then they might have another attack and then get better. And then, as I said to you, over time, they again then just develop slightly insidious again, just kind of not quite getting back to normal. That maybe, you know, after the last relapse, my walking's just not quite as good as it was. And as I said, the symptoms can be very, very broad. They can be around bladder function, bowel function, hand function, feeling, concentration, memory. So it's very, very broad, but it's you, I suppose, noticing a kind of a subtle change over time.
That's great. So that self-monitoring is really, really important then, for, you know, for feeding back to your consultant.
I think so. So the scale I showed you is, you know, it's a real snapshot in time, but that's all it is, you know, and it's quite crude, you know. So you could be, you know, having a good day. When I examine you, your strength could appear completely normal. But if we, you know, if we were to suggest you go for a walk around the corridor for 20 minutes and then come back in, the weakness might be there. So I think there's lots of, you know, very good ways, I guess, that people can get involved and kind of monitor themselves. So I'd often ask people, you know, in terms of going out for a walk, how far can they go? And do they think that that's changed from this time last year? So you can often kind of set yourself a little route and see, you know, am I able to keep up? Am I able to still do the same distance as I was before? And I think there's lots of, you know, other ways of kind of looking at bladder function, looking at memory, you know, kind of testing yourself, seeing, can you, you know, are you as good as you were before? The only thing I would stress, I suppose, around self-monitoring is that, you know, we all know that MS can fluctuate, and it will fluctuate a little bit, you know, and that's not unusual. So I guess not to have it so it's your only focus, and that you're, you know, being aware that things can go a bit up and down, because I think otherwise people then can become very kind of focused, and then it can become quite distressing, you know, if they feel they're getting worse, but actually it's just a little blip in the road. So I think you have to, you know, something that maybe every 3 months, every 6 months, every 12 months, you kind of test yourself that way rather than sort of on a day-to-day basis.
Okay, and we have had a question in from somebody who says that they feel that they are progressing and they haven't had much contact with their neurologist in about 3 years, and they're wondering what's the best way to re-engage to discuss their concerns.
So I would love to say that's not a story you know you never hear in Ireland, but unfortunately access to kind of neurology services is so poor. So I think there's kind of a couple of approaches I would suggest here. So the first thing would be, if you're part of an MS service or a neurology service that has an MS nurse, I think that they are usually really good advocates for patients. So I think they're good people to get in touch with. And I certainly know where I work, they would often come to me if patients have been in touch and have concerns. And that certainly would allow me to kind of bring appointments forward, see people in the clinic a little bit earlier. The other option is always to go to the GP and see, could the GP send in a letter and kind of expressing your concerns. And I suppose otherwise, if you feel you aren't getting anywhere, I don't think it's unreasonable for you to put your concerns in writing and to send it in to your neurologist. And I think that, you know, we would always respond, people would always respond to something that comes in writing. So I think if you have the option of an MS nurse, that's where I go first. And if not, then either sitting down yourself to write something, or chatting to your GP and asking would he contact the neurologist and say that you know you feel like things are changing and that you think you should be seen in the clinic.
Okay, thank you. And we have a question in here on the chat from somebody who's wondering if pushing yourself or maybe overexerting yourself can cause long-term damage for you.
So in terms of you won't cause damage by, say, going out and going for a long walk, other than perhaps straining your muscles a little bit like the rest of us. So you won't damage your nerves by doing that. But I think what it's really important not to do is to push yourself. So say if you're walking to the point where your balance becomes very poor, and then you're at the point of having a fall or have a fall. And then, you know, I would always say to people just to know your limits. And not because you're going to make your MS worse or you're going to make your nerve damage worse. It's more around what could happen if you fell and then fractured your leg or fractured your hip, and the kind of effects then of having to be in hospital, having to be laid up for a while. So I think that's more where I counsel people about knowing their limits. It's not that they're damaging their nerves long term by doing things. It's more, what are the secondary risks? What could happen if I take myself to the point where I can't walk anymore or my balance is gone? What could happen in that scenario?
Thank you. So we have a question as well about deterioration. And so if somebody hasn't had any deterioration for years, but then they start to experience more symptoms, would that indicate that they might need to go on to a disease modifying therapy? And as a quick kind of like add on to that, so there are a couple of people who've emailed in to say that they chose not to go on to a disease modifying therapy when they had relapsing remitting MS, but now that they have progressive MS, they're wondering if it's too late to start.
Okay, so perhaps maybe just the first bit first. So the question there is, someone feels like everything has been very stable for a number of years, but now have some new symptoms. Is that, am I getting that right?
Yes, that's right.
Yeah, perfect. Okay, so what should you do? So I think anytime you have new symptoms, it's worth revisiting things and looking at things again. So I think that may involve, as I said, contacting your MS nurse, arranging a review in clinic. I think it's, always good to be seen. Then we would normally examine someone, see, do we think there's been any change over time? And more than likely would like to update the scan or the imaging and have a look and see, are we seeing any other markers of activity on the scan as well? So I think if something is changing, it's always worth reporting it. I think then it's your physician's responsibility to take that on and investigate it and see, is this something new? Is this a relapse? Is this progression? But I wouldn't do nothing. I would always follow up, but I would always get an opinion if you think something is changing. And then Aoife, your second question was around someone who was never on disease modifying therapy, feels they've progressed a little bit now. Is that right?
That's right. So somebody who started off with relapsing remitting MS and decided not to take a disease modifying therapy at that point, but have now progressed and are wondering if it's too late to start.
So I guess it's very difficult to give you a definitive answer on that question, just not knowing kind of the ins and outs of the case and how you are now. But I would say there's no blanket reason why it would be too late, as long as the evidence to start a treatment now is there. So we do know that in terms of starting treatment in progressive MS, that for it to really make a difference, it depends on how long you've had MS for. So in the case, I suppose, of primary progressive MS, the drug therapies looked at people who'd had MS for somewhere between 10 and 15 years, and their MRI still showed some signs of activity. And they felt in that kind of group of patients, there was a benefit. And then I suppose similarly with more secondary progressive MS, so someone who began with relapses and now things are a bit more progressive, which I think probably fits more in what you're saying. Again, it seems quite clear that if there are signs of activity still there, so whether you're clinically relapsing or whether the MRI is showing some new activity, that again, starting a therapy like siponimod would be helpful for you. So again, I guess the point I would make is that if it's something that you want to revisit now, that you probably should see your physician, see your neurologist. And I think the approach they would take would probably be, again, looking at your exam, having a chat with you, how things have been, and then updating your scan and looking at your imaging.
Okay, thank you. So we do have some questions in around the use of ocrevus, ocrelizumab. A few of them really, so we might just kind of group them together. So one is asking, how does ocrelizumab have a difficult side effect profile, symptoms that are like a worsening of MS? And is there a susceptibility to bad infection or flu-like symptoms with associated MS difficulties from the infection?
From the infusion, is it? In terms of the side effects of ocrevus, so ocrevus is given as an infusion therapy, so that's a through the vein therapy. Some people can get, at the time of the infusion, can get a reaction to it. They can sometimes feel a bit hot, flushed, or nauseated. And usually as part of the protocol, they sometimes give medicines beforehand to dampen down that effect. In terms of the more longer term side effects of it, so ocrevus kind of targets the antibody making cells in your blood. And we do know over time that little proteins in your blood called immunoglobulins can perhaps drop off a little bit. And this is something that does need to be followed kind of on blood tests kind of after your infusions. And that perhaps the risk of infections is a little bit higher in this cohort. In terms of making your MS symptoms worse, there's no evidence of that, say, from trials, but obviously if someone has an infection, that can make your MS symptoms worse. But the drug itself shouldn't make you feel worse, no.
Thank you. And then for people who are maybe concerned about going in to have infusions done or going to clinic at the moment with the COVID-19 pandemic ongoing, would you have any advice for people in relation to that?
Yes, so I mean, all I can say is I completely understand where people are coming from. And obviously this year has been a complete learning curve for all of us and has kind of thrown things around a little bit. I think what I would say is that now we're so far into this and we have a lot of experience that the way clinics have now been set up is, you know, to take into account social distancing. Certainly we're still seeing smaller numbers, but when we're seeing people, we're wearing masks, we're washing our hands, we're wearing aprons to examine people, we're cleaning down the room in between patients. So I think we've made coming to clinic as safe as possible. And I think similar practices are in the infusion suites as well. So I wouldn't feel nervous about coming to clinic. And I think, in fact, by not coming to clinic and not kind of keeping on top of your MS and your MS monitoring, that the risks of that can often be worse in the long term. So I suppose I'd like to reassure people, you know, that we are very conscious of this and we're being extremely careful in hospitals. And certainly where I am, we're not directly, say, in a hospital, we've moved to another department. And I know a lot of hospitals, they're using different entrances or, you know, different pathways and limiting the people around. So I think, you know, I would feel confident and think that people should, you know, attend their outpatient appointments. And I think some of them, you know, if you're nervous about coming in, some of it can be done virtually. So if it's just a kind of a routine checkup and you feel nothing has changed, you know, a lot of us are trying very hard to kind of create virtual appointments. So that's another option, you know, just to say, look, I'm very nervous, nothing's changed. Could the doctor do a telephone or a video call rather than perhaps not having any appointments at all?
And just in relation to ocrelizumab, somebody has asked if you would maybe talk about the effectiveness of it. And there's another question asking for some of, could you please give us the names of the recent drugs you've mentioned? So maybe you just discuss or maybe just re-examine the treatment space.
Yeah, no problem.
Thank you.
So in terms of ocrevus, I'm just going to focus on the trial focus on the results for primary progressive MS, just based on the concept of this talk. So it is a drug that has been licensed for both relapsing MS and primary progressive MS. In terms of the results from the study, so the study looked at people who had primary progressive MS that had been diagnosed within the last 10 to 15 years. And it looked at patients who were aged between 18 and 55. And in terms of entering the trial, they did use that scale I showed you, that EDSS. I'll just see if I can bring it up here. And people had to have an EDSS of 6.5 or less. So that meant that people had to be able to walk with support on both sides, a minimum distance of 20 meters. So that was the kind of main entry criteria. And then the last bit of it was that they had to show they had activity in relation to the MS. And this could be a relapse or this could be activity in terms of MRI scanning. So evidence of when they give you the contrast or give you the gadolinium that there was some lighting up of these lesions. And in terms of then the outcomes, if we look at of ocrevus, when the patient group who got the treatment compared to the group who got the placebo, there was about a 24, I think, % reduction in people showing progression. Okay, so people who got the drug and people got the placebo, there was still some progression, but it was much lower in the treated cohort. And so I suppose that's what we are targeting. And that was kind of looking at things like MRI activity, MRI activity, disability, which was kind of measured by the EDSS, but they also looked at secondary endpoints like hand function and timed walking as well.
That's great, thank you. And with the vaccine launch being imminent, people, I suppose, are wondering whether or not they should maybe delay starting or continuing with their medications, particularly, I suppose, infused medications, with a vaccine around the corner. So would you have any advice there, or would you like to make a comment on that?
Yeah, I think this is a really important question and definitely worth talking. And I think with your neurologist about, because I think it'll vary depending on what kind of treatment you're on, and also what vaccine becomes available and then when it becomes available. So if people are on treatments like interferons and Copaxone, there's no reason why you can't go ahead and get the vaccine, okay? Drugs that affect or target the B lymphocytes, so cause your white cells to drop, and I suppose the one that we're referring to mainly in this talk is ocrelizumab. What we really need to look at there is the timing of the vaccine. So in patients who've had their infusion, what we're looking to see is when their white blood cells have come back up to near normal. And the reason for this is when you get a vaccine, what you're trying to do is induce yourself to make antibodies to that virus. And as I said to you, the ocrevus drug targets the antibody making cells in your blood. So we know that the response to vaccine is not as good. And what is a bit of a question still is that going to be a more long-term thing? And if you've had treatment with ocrevus, will you always mount a good response to a vaccine? And we just don't have the answer to that question yet. The second part, I'd say, just in terms of vaccination in general, I think MS that's untreated, so if you kind of leave MS and it's active and it's untreated, in my opinion, the long-term effects of that are much more serious than the potential of getting a vaccine that may or may not be effective. So I would never delay treatment if your MS was active in the hopes of a vaccine when we don't yet know when it's going to be here or how you'd respond to it. That would be my opinion. And then the other thing with vaccination that we just need to be careful about is the type of vaccine. So live, non-live. I think the majority of what we're going to get here are probably going to be non-live vaccines.
We do have a couple more questions after coming in just in relation to COVID-19. So people are wondering if COVID-19, if people living with MS have, I suppose, a more severe experience with COVID-19.
In general.
Yeah.
So I think this again is really interesting, and I suppose the answer is it really depends on the MS and how long you've had MS. So overall, in the kind of larger studies that have come out, they've showed that people with MS don't get a worse COVID than the general population. And then when they looked within people in the population with people with MS who got COVID, that there were certain drugs that seem to predispose people to the infection a little bit more. And one of those was ocrelizumab. So just to be aware of that. Now, overall, there was no increased risk of death or severe infection, but you were more likely to get it if you were on ocrelizumab. And when they looked at the people with ocrelizumab who got the more severe infection, they saw that they had other risk factors for COVID. And I think this is something that we need to be aware of. So as we know, you're more susceptible to COVID if you're a bit older, if you're male, if you have high blood pressure, if you have significant diabetes or asthma. So I think when they look back at it, the kind of the factors that predispose people perhaps to a slightly more severe infection seem to center around things like duration of MS, how disabled they were, age, and the other comorbidities that we know are associated with COVID. So as a general principle, people with MS don't seem to get more severe disease than the general population. And those who perhaps were more likely to get COVID tended to have other risk factors that we know are associated with COVID.
Thank you. And then, so moving away from COVID a little bit, we do have a few more questions, I suppose, general questions. One is asking about the autoimmune cause in MS. So they find that people often discuss the neurological aspect, but they're wondering about the autoimmune element of it, and if you might discuss that a little.
So I suppose the cause of MS is somewhat elusive still after many, many years of trying to tease out what is happening. And I suppose we call it an autoimmune disease because we feel, for whatever reason, our body has developed a kind of an intolerance to self, and in essence is attacking itself. And I suppose that's the kind of the basis behind describing it as an autoimmune disease. And that's why a lot of the therapies are targeting or trying to modify different aspects of the immune system. Is the question, perhaps the author might just expand a little bit more, are you wondering more in terms of cause, or are you wondering more in terms of kind of how it affects the disease going forward? I don't know, Aoife, if they might come back to you and expand that question.
Absolutely.
Or
So
do you feel I'm missing something? I'm just not quite sure where they.
No. If the person would like to expand on it, they can send it back in through the chat function if they want to be a little bit maybe more specific about it. And in the meantime, then we might just ask about MRIs for people with progressive MS. So some people experience a kind of that they have decreased number of MRIs as they continue, I suppose, in their progression. So is that, do MRIs get less frequent with progression?
Okay, so I guess there's not kind of one size fits all in this regard. So I think patients who are probably still on their disease modifying therapy, I would still aim to carry out an MRI every 12 months. If people are off therapy and they feel that they're very stable, you may not need to carry out the MRI quite as often as that, and perhaps would be guided perhaps more by if something is changing more radically. So if they were suddenly deteriorating, then that might be more of an indication to kind of arranging the MRIs more frequently. And I think in patients who perhaps are non-mobile and not on therapy, the kind of window between MRIs probably doesn't need to be as frequent as 12 months, and because we know the chances of seeing something on the scan are very small. And obviously trying to get in for the scan and the kind of difficulty with kind of lying flat and the long period of the scan, that it really isn't probably necessary to do it as frequently as that. So I wouldn't say there's a hard and fast rule, but I think if you're still on therapy, that it still is prudent to do an MRI about every 12 months. I think if perhaps you've been very stable for a number of years, you're not walking and you're not on treatment, it's not necessary to do scans as frequently as that.
Okay. And just to go back to the other question then, so it was in relation to the autoimmune cause of MS.
Okay, so this is the $1 million question, and you can see this teased out a lot. So what causes MS? And it felt to be kind of a combination of factors. So kind of environmental, and the ones that I suppose come up a lot are things like EBV, and then there's other, I suppose the commonest one being EBV, and then we know kind of in terms of latitude and spread around the world that it's obviously much more common as you move further away from the equator. And other factors then like smoking, obesity play perhaps a smaller role in it. And then in terms of genetics, so we have seen that genes that are associated with immune function have been incorporated in the cause of MS, but it's very broad. It's not a single gene that causes this. And we think these kind of factors combine to set off a path of kind of immune dysregulation, and that's what causes this. And I think you hear sometimes, and perhaps this is what the question alludes to, but I'm sorry if I'm not answering it the way you wanted to, is what drives the disease? Is it a kind of a T cell disease or a B cell disease? And I think there's no kind of clear consensus on that. But I think the best way of thinking about it is that something has kind of set off an episode of kind of dysregulation within the immune system. And for whatever reason, the body is kind of recognizing itself as a foreign invader and attacking itself. And that's why some of the therapies, I suppose, are targeted towards kind of regulating or modulating or suppressing the immune system.
Thank you. And we have some questions in, I suppose, that we'd look at as, I suppose, symptom management ones maybe. So there's one just come in from somebody who has issues with balance problems and attacks of vertigo. And they're wondering if there are any medications available to help them with that kind of problem.
Yes, so there are lots of treatments. So I suppose for vertigo itself, if you kind of experience kind of true spinning, there are a couple of tablet therapies that are often worth trying. And some of them are drugs that you might be familiar with because they sometimes treat kind of nausea, so Stemetil or another therapy called Circ. And so I think it's always worth trialing those things and seeing, do they help? In terms of balance, so I think balance, it's probably a combination of factors. So I think it's the biggest thing I think would be working around kind of physiotherapy in terms of balance. So trying to strengthen up the muscles, and then also look at potentially aids that can kind of help and keep you safe. So they would be the kind of things that I would look at with regards to that.
And then similarly with, let's say, the likes of increased bladder urgency, are there interventions available for people?
Yeah, so I think this is a huge symptom, and it can be really troublesome. You know, you're preparing to go out for the day, you go to the loo, you get in the car, and then you want to go again, and it's very common in MS. But there are lots of tablet therapies that can be tried that are usually reasonably effective. They kind of reduce that urge to go. And in very severe cases, they look at doing a procedure where they inject some Botox into the muscle within the bladder, and that can be very effective as well. So it's definitely worth a discussion and definitely worth a trial. There are lots of options out there.
We had somebody contact us who said that their hands, they feel that they move very slowly in the winter. So when they write, when they type, that their hands are just moving slower than they would like for them to. So are there interventions available to help people with that?
I suppose it's interesting that they feel they're worse than the cold. I think maybe generally we all feel like we slow down a little bit in the cold. You know, MS is typically, actually what we see is that in very hot weather, warm weather, people's MS will get worse. And we know this because it kind of slows down the conduction along the nerve. So in terms of if they feel they've got stiffness in the hands and they're a bit slower, I think one of the simple things that I would do is make sure that it's not something else. Okay, so to make sure it's not something else that's treatable, and particularly the things you think about are arthritis. So it'd be worth kind of having someone examine the hands, so either the GP or your neurologist. And if they thought there was anything else going on, there might be a few blood tests or x-rays that might needed to be done. If it was the other thing that is very common and not related to the MS is a thing called carpal tunnel syndrome. And again, that can affect hand function, make the hands feel a little bit weak, and sometimes some sensory symptoms in the hands. So I think it'd be important first to make sure that it really is the MS. And then if it is the MS and perhaps the circulation is just not as good, then things like wearing gloves indoors, kind of stretching out the hands, those kind of things can sometimes be very helpful.
Okay, thank you. And we have a comment in here from somebody who says that they've recently been told that they have moved to relapsing progressive MS. Could you maybe chat about what relapsing progressive MS? It's not a term that's used very often. So if you could chat about that, it would be great.
Yeah, so I think it's kind of an old term, and I think now people would probably say that that's more of an active progressive MS. I suppose in the old terminology, when they talked about relapsing progressive, what they meant was that things maybe are getting a little bit worse, as we talked of before, you know, this kind of insidious worsening, but you're also having kind of new symptoms superimposed on top of it. And I think that's what they mean by that. So perhaps yourself, you might have noticed that, you know, you haven't quite come back to normal, that things are getting a little bit worse, be it your walking, your balance, but then you're also getting these new symptoms, perhaps like an optic neuritis or something on top of that. And so I think that's what they mean when they say relapsing progressive MS.
Thank you. And could you maybe just discuss the difference between the medication? So some people feel that there's lots of medications, I suppose, for relapsing and remitting MS, and then there's fewer for progressive MS. So can you maybe chat about, like, you know, are there many drugs in development? Is it a kind of a bright horizon, I suppose, for progressive MS?
So yeah, I think it's challenging. So what we feel happens maybe in progressive MS versus, say, relapsing remitting MS is that there has been kind of nerve damage or loss of nerves and nerve fibers, whereas in the earlier stages of MS we think that there's kind of acute damage to them, but they can heal themselves and recover a little bit. And I guess that's what makes it so challenging to treat progressive MS, because we don't have lots of therapies, I guess, that are good at restoring nerve function. And we can see this from people who've had, you know, say, spinal cord injuries and things like that. I think what's really interesting in MS, and unfortunately to date they haven't quite found the right agent, but there's still lots of work going on in this area, is looking at drugs that kind of target remyelination. So if you like, the nerve fiber has a kind of a fleecy blanket or a covering around it that gets damaged in MS, and that's kind of the hallmark of the kind of pathology. And there's been a number of therapies trials targeting to grow that kind of cover back or remyelinate the nerve. Unfortunately, to date, they haven't been positive. But I think what is really interesting is that we now have had therapies that are licensed for progressive MS, albeit perhaps in the earlier stages than some people would like. And I think that work is definitely ongoing in that area. So if you look up clinical trials, you know, and look up progressive MS, you'll see, you know, a series of drugs going through trials. And so I would expect that more will be licensed over time. It's just we haven't quite hit on the one that kind of targets the more loss of neurons and the more long-term damage that we see in MS. And I think that's really what we're chasing down and trying to get.
And is it possible for people who to switch medications if they have progressive MS? And specifically, this person is asking about potentially changing from rituximab to ocrelizumab.
Yes, so it's not I mean, these questions again, I'm sorry, not knowing the individual case, but there's no reason why you couldn't switch from rituximab to ocrelizumab if you fulfilled the criteria that the ocrelizumab was licensed for, and that might be a stumbling block in some cases. But so, you know, if you had primary progressive MS that was recently enough diagnosed, and at the time, I suppose, of going on the rituximab, you had some activity on your scan, hence the reason to start it, and there should be no issue with switching between the two. So it will depend a little bit on your clinical case, you know, depending on whether it would be covered under the kind of the license for the ocrevus. But what I would say is they're very similar, those two medications, with kind of very similar efficacy. So, you know, both very good drugs and very, very similar.
Thank you. And we've a question in from somebody else about the use of modafinil and if it's safe to use to combat tiredness.
Yeah, so it's a mild stimulant, and it's used a little bit in conditions like narcolepsy, and it certainly is worth trying. I think, in my experience, fatigue is one of the hardest symptoms, and both it's obviously very distressing for the person who feels fatigued all the time, And it's also very challenging to try and manage it. So I think it's always worth a trial. And I would suggest, usually it's a twice a day tablet, and usually take it early in the morning and then around lunchtime, because occasionally it can affect things like sleep. And things just to watch out for, I guess, is that some of these drugs occasionally can exacerbate things like anxiety and restlessness. But I would certainly think it's worth trying to see if they can manage fatigue.
Thank you. And do you have any advice for people with progressive MS who may have less ability, so they might have an accumulation of disability, to kind of keep themselves well during a time like this where they have been advised to cocoon, they're having to stay at home a little bit more, and do you have any advice for them on kind of general health and well-being?
Yeah, I mean, I think the cocooning thing is, we've seen that it hasn't been terribly successful, that kind of concept, you know, of telling people not to leave their house at all. I think what I would more kind of say to people is to try and get out, but kind of pick your time very carefully. So to try and get out for short periods, say during the day when no one else is around. So if you know, have a local park, if the kids are in school, it's a quiet time at 10 in the morning, to try and go out then, and obviously maintain the kind of physical distancing that's been advised, and wear your mask if you're in close contact with people. In terms of at home, I mean, I would give the kind of same general advice, and you know, in terms of trying to keep brain active. So if you like reading, to continue to read. You know, your brain is a muscle too, and it does need to be exercised. If you like puzzles, Sudoku, there's lots of online kind of games now that are kind of brain training, and I think they're all really worthwhile. Then from a physical point of view, I suppose it's looking around the house and seeing, you know, what can you do? Can you set up a bit of a kind of a circuit station? Can you get out maybe the cans of beans and do some, you know, arm exercises? And if you look online now, there's quite a lot of exercise classes. So I know there's a program that we would refer people into a little bit called Xwell in the community. And these are kind of online exercise classes that are kind of specially tailored towards people and doing exercises in their own homes or their own locale. So I think they would be worth looking into. So yeah, just generally trying to keep kind of active. But I wouldn't advocate cocooning completely. I would try. I think it's good for mental health to get out a little bit. It's just about kind of choosing your time carefully and avoiding crowded places. Have I lost you, Aoife?
Apologies. I was just saying that I'm afraid we're going to have to wrap up in just a minute, so we might just take two more questions. So one is about, again, we're back to ocrevus, and can ocrevus be used for people with primary progressive MS?
So that is the license. So the license is obviously for relapsing remitting MS, but the license is for primary progressive MS. Now, within the context of the trial, and the kind of what's the guidance that comes down, the licensing guidance, it is kind of early within the disease course. So as I said to you, kind of within 10 to 15 years of diagnosis. And I suppose one of the other kind of key indicators for it is that there is some evidence of activity or enhancement on the scan.
Great. And we'll just take one more. So again, this is in relation to people feeling like they have progression. So if somebody who has had MS for 35 years and they are experiencing a new symptom now, having been they haven't had a new symptom in that time, is that something that is worth flagging? So essentially, is it, you know, I suppose largely is anything like that, any new symptom, even if you have progressive MS, is that something that you should flag with your neurologist?
Yeah, absolutely. I think, as I said before, and I think, you know, in centres where there is an MS nurse, I think they're a great first point of contact, you know, and so that would be the person I'd advocate going to. And if you don't have that in place, I think definitely, you know, asking the GP to write in. I think any new symptom needs to be seen and assessed.
That's great. Well, that about brings us to time. Thank you so much, Dr. O'Connell, for joining us this evening and for answering so many of those questions. I think that people will really feel much more informed about progressive MS now, and it's great to have so many questions answered. And thanks also to everybody who has joined us this evening and sent in your questions. It's great to have you all involved, and we were delighted to be able to do something like this for people with progressive MS. So thank you, everybody, and I hope you all have a wonderful evening.
Can I just reiterate, I suppose, what Aoife said. It's great to do this. I think there is something lost in not being able to see people and not being able to directly answer your questions. So it's sometimes a little bit artificial, but I hope we did our best just to kind of touch on topics. And yeah, thank you very much for your time and for all your questions.
Thank you very much.